York Army Medical Center presents a United States Army Medical Department continuing education program, Psychological Reaction in Oral Surgery, with Edward C. Hines, M.D., DDS, Chairman, Department of Surgery, University of Texas Dental Branch at Houston, and Consultant in Oral Surgery for the United States Army and Veterans Administration.
I'd like to join all of you in welcoming the return of rain to San Antonio, which reminds me of a story of the drunk that came home late at night, drove into the garage, got out and turned the washing machine on. His wife, being concerned, went out to the garage and asked him what he was doing. He said he was watching the ball game, but it was raining like hell in St. Louis. Today we're going to talk about psychological reactions. And you all know it's really not such a bad world after all, as soon as we become used to being nervous about everything. Paul Tillich, the eminent theologian, has made some pertinent comments about the relationship between health and emotions. He noted that what scholars have called the miracles of Jesus are really examples for our current day of the necessity to achieve health by restoring the elements of faith to some sort of order. There is healing power in nature, and much healing is possible if this power is wisely used and skillfully aided. Those who despise this aid and rely on the power of their will ignore both the destructive might and the constructive friendliness of nature. They do not know that our body contains not only forces of discord between its elements, but also forces of concord. The great physician is he who does not easily cut off parts and does not easily suppress the one function in favor of the other, but he who strengthens the whole so that within the unity of the body the struggling elements can be reconciled. And this is possible even if deep traces of former struggles in our body remain as long as we live. And physicians also are subject to emotional influences. You know, it takes courage to be a surgeon. Dr. T.R. Van Dellen, in one of his daily columns, took note that in 1902, Sir Lauder Brunton, a top-rated surgeon, suggested a way to mechanically enlarge a narrowed, scarred heart valve. His reward was a scathing attack by the editor of The Lancet, and as a result, he never tried it. In 1925, Dr. H.S. Sutar did the operation as suggested by Sir Brunton, and the procedure was successful. This took great courage, but he was criticized and never repeated the operation because he was unable to get another case. In 1948, Dr. Charles P. Bailey devised a special knife to cut and widen the narrowed valve. He attempted the operation 3 times in 3 different Philadelphia hospitals. All attempts failed, and he was denied the use of these facilities. 2 hospitals still allowed him the right to operate, but he knew that another failure would be the end. Dr. Bailey summoned enough courage to schedule 2 operations on the same day, one in each of these hospitals. The first failed, and he ran to the next hospital before they got the news. His 5th operation was successful, and a new era of cardiac surgery began. As you know, today heart surgery is routine. Psychology applies to the broad field of medicine in many ways, and though what I have to say is mainly directed toward empathy to the patient, psychological factors can have a strong influence on the quality and amount of work we may perform. Man is an emotional animal, and I have been told that the coach of the Grambling College football team, when looking for material, seeks out an individual who is mobile, agile, and hostile. And so we know that man has hatreds and rages, but he also has love and affection and empathy. Man is an emotional animal, and some have said this is one way in which we differ considerably from other animals. Psychologists have developed a number of what they call constructs, such as the id, the ego, and the superego, to better understand emotional behavior, sometimes referred to as the behavior of the inner man. Accordingly, we find that we all have a number of unconscious or subconscious needs, fears, hostilities, and so forth, modified by our past experiences which influence our overt actions. It has been said that the individual is static and that his potential will not be changed by alteration of his physical appearance. On the contrary, we have seen many instances of marked transformation in patients who have had surgical correction of jaw deformities. One of the most common emotional phenomena is a universal fear of surgery and particularly dental treatment. Too often it does not impress us adequately. It is only when we are a patient that the truth strikes home. As doctors, we would all do well to put ourselves in the patient's role. In some busy offices, a nurse is called upon to obtain the history from the patient. A certain number of these patients, perhaps all of them, at least secretly, resent this apparent lack of interest on the part of the physician. In the letters to the editor's section of Modern Medicine, Robert Loeb comments on an article by Michael Halbertson, Are You a Stranger to Your Patients?, in which Halbertson asserts that compassion and understanding can be taught just like orthopedics or any medical subject. Loeb disagreed. He said, either you sense feelings or you don't. You can learn manners, but the capacity for compassion and understanding is inborn. Maybe so, maybe not. But along these lines, I would like to quote from 3 articles. The first being Nonspecific Forces Surrounding Disease and the Treatment of Disease by Henry K. Beecher. It appears that voodoo writes, fear or emotion can kill and they can save. It seems probable that placebo effects are not unrelated. The traditional expectation is that placebos will improve. It hardly seems too much to suppose that a mechanism related to that which they operate under can also exert deleterious effects. Nonspecific forces can kill, and having this ultimate power, it is only to be expected that they can affect disease and its treatment in lesser but still serious ways, sometimes favorably, sometimes unfavorably. Moreover, disease can be produced by nonspecific forces, peptic ulcer being a case in point, and I suspect that temporomandibular joint pain falls in the same category. There are intrinsic factors involving the patient and extrinsic factors involving the physician. The first is exemplified by the fact that only 1/4 of the soldiers injured on the beach at Anzio during World War II required medication for the pain of great wounds. The situation is reversed when smaller wounds of civilian surgery are involved. Similarly, a study carried out on individuals who had missiles lodged in their heart, but who had no organic problems as a result, when compared with a group of individuals who had prostheses placed within their heart for therapeutic purposes, fared much worse from the standpoint of the psychological reaction to these situations. The extrinsic factor is well demonstrated by the enthusiastic physician. I have heard residents from the Mayo Clinic describe such enthusiasm in Dr. Bargan, an internist who specialized in intestinal diseases. He had a special regimen for management of ulcerated colitis with which he obtained great success, but nobody else could duplicate. It was the feeling of the people about Dr. Bargan that the big factor in his success was simply his own contagious enthusiasm. Dr. Lindsay Beaton wrote on psychologic necessities in surgical education. To every patient, any surgery is an emotional trial. It makes a great difference if the surgeon, the authority figure, is unconsciously visualized as an omnipotent but kindly father or an angry and disapproving one. Surgeons, and probably dental surgeons as well, too often do not recognize or appreciate the apprehension present in all surgical patients. Surgeons as a group tend to be authoritative, self-confident, aggressive, practical, and objective, and would seem like the most unpsychologically minded of all physicians, who as a group are not very psychologically minded anyway. Most do not intuitively learn the principles of compassionate management of their patients' psychological problems. Hence the importance of psychiatric training. There is, of course, the other side of the coin. Psychiatrists may also profit by renewed association with the somatic side of human illness, as demonstrated by the psychiatric resident who told his patient, "Madam, there is nothing wrong with you, it's all in your body." And finally, from an article by Tinsley Harrison, the most disturbing symptom, he differentiates between diseases which threaten happiness and are distressing, and those which threaten life and are dangerous. From the standpoint of threat to happiness, fear is clearly the most distressing symptom because it causes more total suffering than all others combined. And it is interesting to note the results of a Gallup poll made several years ago regarding fear of various disease processes. 62% of those polled feared cancer more than any other disease. Only 18% feared blindness most, and strangely enough, the most threatening of all diseases, heart disease, was feared by only 9%. There is a strange excessive fear of cancer. This involves such things as fear of mutilation, fear of loss of control, fear of damage to the body image, fear of submission, and fear of death. The oral cavity is extremely charged with emotional significance. In the management of disease, we must never forget the importance of history-taking, particularly the social and psychological history. This idea has probably never been better expressed than in a recent article by Colonel John Tarsitano, an Air Force oral surgeon, entitled Never Treat a Stranger. John Stalin, writing on the psychological aspects of cancer treatment, stated, "Suggestions for therapy are founded upon the simple concept that two human beings, the patient and the surgeon, each with his own personality structure, are involved in a relationship on which the patient is to an enormous degree dependent for understanding and support. The indispensable ingredient of this therapeutic approach is free communication between the surgeon and the patient, in which the latter is sustained by hope within a framework of reality." I would like to summarize for you two hospital studies which support these ideas. The first, from Massachusetts General Hospital, was carried out on 97 patients subjected to elective intra-abdominal surgery. They were divided into two groups by random order. 51 of these patients, the control group, were not told about postoperative pain by the anesthetist. The special care group, consisting of 46 patients, were told about postoperative pain. They were informed where they would feel pain, how severe it would be, and how long it would last, and reassured that having pain was normal after abdominal operations. As soon as the patients appeared aware of the nature of the suffering that would begin on the following day, they were told what would be done about the pain. They were told several different things that they themselves could do to help minimize the pain, and if they needed it, medication was available. The surgeons were not aware that the patients were being so instructed. Following surgery, the study group was again visited by the investigators and encouraged and further instructed. The results of this study showed that they were able to reduce the postoperative narcotic requirements by half in the study group. The patients who were encouraged during the immediate postoperative period by their anesthetists were considered by their surgeons ready for discharge from the hospital 3 days before the control patients. And from Columbia Presbyterian Hospital in New York, where a number of cardiac catheterizations were being carried out on children, it appeared that the hemodynamics were so influenced by premedication and general anesthesia that the results could not be trusted. Consequently, the cardiology team undertook to bring the children in ahead of time and discuss with them what was to be done, to reassure them that it was not significantly painful and what was being done to help them. Accordingly, they proceeded to do these cardiac catheterizations under local anesthesia and found that this latter group of children responded much better psychologically than those who were premedicated and given general anesthesia but told nothing about the procedures that were to be carried out. And now let's look at a few cases. This is our old friend Mr. Schultz and Peanuts. And the moral of this slide, of course, is that our daily battles have to be fought over and over. I call this the adult male syndrome. These people come in to have an extraction, and they seem to be in excellent health. Frequently, they may be a 240-pound football player, 6 foot 5 inches tall, and all goes well. And the injection is made, as you see here, and about the time you finish the injection and you ask the patient how he's feeling, he says, "Fine," and then he slumps over in a faint. This is typical of adult males, and I think is related to the fact that the male animal is taught from childhood that he should not cry and he should not be a coward, so that when he gets in a situation like this, he can't fight and he can't run, so all he has left to do then is faint. You very seldom see this in women. The fear of cancer is probably the greatest fear in the medical field. Here's a lady who has reached a point in life where she has many psychological problems. Her children are grown up and they have left home, and her husband has developed other interests, and she then is left to brood to herself. Now, this particular lady developed a temporomandibular joint syndrome. She had severe pain and had seen many physicians and dentists with regard to it and was under treatment at this time. She had had a large lesion on her nose present for 1 year. She had been told by many physicians and dentists that something should be done about this. But it wasn't until we had her hospitalized one day for her temporomandibular joint pain that she allowed us to go ahead and treat this lesion on her nose, which turned out to be a malignant tumor. And I think this is an excellent example of how some people try to avoid recognizing the fact that they may have a malignant disease. The slides depict the treatment. Of course, the basic feature is wide excision, followed by development of an adjacent skin flap and primary closure, which gives a very nice result. This tumor was very successfully treated. She has had no recurrence and no longer has this particular problem to contend with. The gentleman that you see on the screen now is a well-known TV actor and writer in Houston who had a malignant tumor of the parotid gland and was operated on several different times. He was so impressed by the emotional significance of cancer that he wrote a play and acted in that play. The MD Anderson Cancer Hospital in Houston was so impressed with this play that they bought a number of prints of it. I would like to quote a few lines from the play that this gentleman wrote. It's entitled, "The Many Faces of Fear." The workings of fear upon the mind are most imperceptible at first. There is usually rejection of a dark suspicion, eventually a cancellation of action. You say, don't be a hypochondriac, or there's nothing wrong, it's just your imagination. This is something you can handle yourself. There's no possibility of anything dreadful or unusual or strange. The mind of man has no love for unpleasantness, and the conscious mind, if at all possible, will skirt and reject an ugly idea which it does not care to be confronted with. I suppose now that I look back, I finally did go to a doctor on the basis of appearance. How curious. I was not admitting the possibility of a tumor, not openly. I went prompted by a sense of correcting a disfigurement. And later on, in concluding, I could not face my future without fear, or at least without the fear that paralyzes. I have been warned that recurrences may happen in the future. The lesions may appear again, but as my doctor said, we know now the type of tumor that you have and the best way to treat it. My life resumes. I read a statement the other day written by Thomas Carlyle, which I have committed to memory. It goes, the first duty of man is that of subduing fear. We must get rid of fear. We cannot act at all until then. A man's acts are slavish, not true but specious. His very thoughts are false. He thinks too as a slave and a coward till he hath got fear under his feet. Now, the unusual thing about this gentleman was I saw him because he had developed some infection in a jawbone. And I saw him over a period of about 3 months. And on the occasion of my last visit, he had lost considerable weight and did not look well at all. He missed 2 or 3 appointments, and I checked with his physician and found out that he had been hospitalized. And not only that, but even before he first came to me, he himself knew of some masses in his lower extremity which he observed for several months without telling any of his doctors. This, of course, represented metastasis, and this man expired from his disease. We have the problem of family influence. in the management of certain individuals. This is a young boy who had multiple developmental deformities. The one that I saw him about was a underdeveloped chin. Now, at the time that we treated him, we were not doing osteotomies and sliding the chin forward, and we were not using implants, but we were depending on bone grafts. And this boy was so frail, we could not get bone from his hip. So at the advice of the orthopedic surgeons, we took fresh bone from his father's hip. And his father was a very handsome, very dynamic person. This was his only child. He was quite disturbed about his son's condition. This is the immediate result of our placing bone from the father's hip in his chin, which was not too bad. But unfortunately, he developed infection and for several weeks exhibited draining sinuses. And the result in the long run was not what we had expected. But I must confess, I was shocked when I was driving in my car one Saturday afternoon, and I heard the announcement on the radio that this man had shot and killed his son and turned a gun on himself and killed himself. Now here we have another problem in family relationships. This young man was injured in an automobile accident, had bilateral fractures of the mandible, and subsequently developed osteomyelitis. He ended up with a shortened mandible that looked not at all like he had looked before the injury, but looked more like his father. For some reason or other, he had an intense hatred for his father. So over the next 3 or 4 years, we did several operations on this young man, including implants and bone grafts and even a facelift at his insistence, in order to try to reproduce his original appearance, and particularly to make him so that he would not look like his father. And incidentally, also during this time, he deserted his wife and small child and required the help of a urological consultant for impotence. Eventually, after many operations, we were able to produce the profile that this man wanted. And it is hoped that his psychological problems have been solved. It's the problem of the chronic alcoholic and the depressed. This lady had been a chronic alcoholic for many years. She had shot herself and with complete destruction of the lower jaw. She was sent to us for a bone graft. Another chronic alcoholic, a male, had married this lady several years earlier, and since the day he married her and was able to encourage her and help her, he had not taken a drink. Now, we did 3 large operations in attempt to reconstruct this lady's mandible. As you can see here, very complicated fixation appliances were applied, and extensive grafts of the rib and hip were used to try to rebuild the entire mandible. We had reached a point of some success, and she was due to return for another visit when we got word that she had developed pneumonia and died. And on the occasion of her death, her husband, who had not taken a drink in 10 years, went back to the use of alcohol again. This is the x-ray showing her lack of a mandible, and another x-ray, a Panorex, showing the amount of bone that has been placed in the area for reconstruction. This is a fairly common problem that we as dental surgeons should be familiar with. It has to do with the loss of teeth. Now, this lady was faced with a full mouth extraction. To her, this was a sign that she was growing old and unattractive. She became very depressed, and as a matter of fact, canceled her admission to the hospital on 2 different occasions. Her trouble was further compounded by the fact that one of her friends very thoughtfully told her of another friend who had gone into the hospital to have teeth removed and never recovered from the anesthetic. However, with empathy and kindness, understanding, this lady came around, and you see her here now wearing her new dentures, having adjusted to her temporary depression, and now very happy and well adjusted. But these are problems that should be recognized and treated. We have another problem of trying to decide whether a symptom is due to an organic reason or a psychological reason. Here's a young man about 25 or 26 years old who has had severe temporomandibular joint pain for many years. This man had a dominant physician father who had died rather suddenly. The boy had never become well acquainted with him. His mother was inadequate to deal with his problem. He had been seen by many people and treated for his temporomandibular joint pain without success. It had been suggested by someone that perhaps if we did a vertical subcondylar osteotomy and let his condyles go free, this would solve his problem. But it occurred to me that with his malocclusion, we should first attempt to put his teeth in proper occlusion. As you can see, he has a receding chin. This certainly is not good for his own lack of belief in himself. So the first thing that we did was to do an anterior maxillary osteotomy. The next 2 slides, I believe, will show the models and show the protrusion of the maxilla, which we felt should be corrected first. And as a matter of fact, following performance of the anterior maxillary osteotomy, he did get some changes in his symptoms and some improvement. They did not completely disappear, and we then went ahead and did a vertical subcondylar osteotomy, wired his teeth together for 4 weeks, and let his condyles float free to find a new functional position. We followed him then for about 18 months, during which times his symptoms were almost completely absent. It's a young man with a prognathic jaw that was referred to us by one of my dentist friends. And incidentally, he told me that he had taken his wisdom teeth out a month or so earlier and that he bled excessively and that we should beware of this. We did many hematologic studies on this boy prior to surgery and found nothing out of order, and concluded that the dentist was worrying unnecessarily. At any rate, when he arrived in the operating room suite, he handed me this note. "Good luck, Doc. Scaredly yours, PZ." I never had that experience before, but it turned out that the dentist was right. This young man did bleed excessively, in spite of our not being able to find any pathological abnormality. But you can see the extensive swelling. He's even got hematoma in the lobes of his ears. And if you'll notice this photograph of his chest, he's got ecchymosis all over the anterior chest wall. So it pays to listen to what people tell you. This is a post-operative film. Incidentally, this boy later kept in touch with me by letter, and he is now a sophomore dental student at our school. These are examples of unusual, unexpected reactions. Here's another one. This is a boy about 12 years old. His parents were visiting the hospital, and he got in the parking garage at Methodist Hospital and went up on that little elevator that they go up to pick up the cars, and he slid down 4 floors. This is a lateral view showing what happened to his upper anterior teeth. They're headed straight north. And so this is what I found. Incidentally, this was a night before a trip I was supposed to make over here to Brooke Army Hospital. You see his central incisors are coming straight at you. Well, this little boy, it didn't knock him out or anything. He was conscious, and he was lying there on a stretcher and asking me all about the hospital and operating and dentistry, and a really wide-awake kid. And just before they put the mask on his face, he said, "Happy operation, Doc." So, you know, that gave me great courage. But this is what we did. We put a bar on that and put some quick-setting acrylic, and we put that the displaced alveolus back into a normal position, and he got a pretty good result. He's a real great kid. And we've had him back in recently. It's about 3 or 4 years after his injury. I'll show you these recent pictures here in a minute. But these are post-operative pictures. And here's a recent picture we got of him. He's still got that great optimistic attitude. Be a great dentist. See if we can show a picture of his occlusion there. Not too bad after 4 floors. Now, this is another patient of mine. It's a young lady who we were going to take some wisdom teeth out for. And as I walked up to the operating room, she had 6 or 8 residents around the stretcher there just in stitches, laughing. It's rather unusual for a patient about to undergo anesthesia and surgery to be in such a good mood. Of course, her husband and her boyfriend both had visited her the previous night, and I suppose she had reason to be happy. But I said, "What's going on here?" And she said, "Well, I was just telling them a little story." I said, "Well, what was the story?" He says, "This little baby was born and laughing, just laughing incessantly, and he couldn't stop. And a doctor slapped the baby on the bottom and did everything he could think of, try to stop this baby from laughing, couldn't stop him. So he said he started examining me, and he examined his hands and his fingers, and he opened each one of his fingers. Didn't find anything until he got to the last finger, and he opened this up, and here was a birth control pill." Oh, well, you know, the surgeon has to have morale boosters, too. And these are our morale boosters. Very nice folks, our operating room nurse personnel. Real great folks. I wouldn't be able to get along without them. Now, we have some different individuals react differently to problems. And here's a young lady who had a 3rd molar removed and incurred a burn of the lip from the handpiece. It was a rather small burn, but this girl became quite vindictive. Here's a close-up showing the minor character of this thing, and developed a very intense antagonism toward the surgeon. As a matter of fact, she tried to get him to excise this thing a couple times, and when it didn't come out with a perfect result, her antagonism just increased. Now, this is in contrast to this beautiful young lady who had a burn which was really more severe, but felt no antagonism toward the operating surgeon whatsoever. As a matter of fact, she seemed to be rather taken with him. So there are all kinds of emotional problems that we have to beware of. But this is an example of different reactions in different individuals. This is some patients are more fastidious than others. Here's a lady, very nice lady, with her prognathism and asymmetry. Although she was in her 40s, she was very anxious to have something done about this and to point out to you the extent of her fastidiousness. Her dentist tried to set the teeth up for her the way she wanted, and he could never get them quite right. So he said to her, "Now here, I tell you what, you take the alcohol burner and the wax and the spatula and the teeth home, you set the teeth up, bring them back to me, and we'll process them." So those were the teeth that she set up. We did do surgery on her, and we moved her mandible back 19 millimeters and laterally 14 millimeters with a very nice result, and with a situation that would allow her dentist then to set the teeth up himself, as you see here, and so that she was then satisfied with the final result. Tension reactions. We have some very interesting tension reactions. Here's a lady who has had for a number of years refractory stomatitis. It's recurrent, and there seems to be nothing that can be done to get rid of it. She also has a mandibular prognathism. She was referred to us with these complaints, and certainly we felt that she could benefit by surgical correction of the prognathism, which we proceeded to do. Here you see her preoperative occlusion and the postoperative photographs after setting the mandible back. And the unusual thing was that after having this surgery, she never had another attack of stomatitis. So that we must assume then that her refractory stomatitis was associated with her mandibular prognathism. Here's another patient. Now, this is a postoperative view of the occlusion of the same patient. But here's a patient who has a mandibular asymmetry, or a lateral anaphthia. She also has low-grade fever of undetermined origin. She'd had a complete workup, systemic workup. She had had some urological infection corrected. She persisted in having this low-grade fever. Again, here was a lady who had a very obvious deformity that was subject to surgical correction, and we did vertical osteotomies on her ramus and moved her mandible over into a normal position, as you see here. And again, following surgery, this individual's low-grade fever of undetermined origin disappeared and has not returned. These are what we might call beneficial reactions. Some people say these things don't happen, but I contend that they do. Here's a lady who is one of a set of twins. At the time she was born, she was deserted because they thought she was stillborn. All the attention was directed toward the other twin. And as a matter of fact, she did live. She survived. But at birth, she had an asymmetry of her face, apparently due to intrauterine pressure. Now, this is the way she looked at the time we first saw her. She's got an asymmetry. It's somewhat unusual. It gives her a look that is not exactly attractive, and this is what her occlusion looks like. And on the X-ray, you see that contrary to most asymmetries, which will demonstrate a large condyle on one side, she's got a small condyle on one side, so that this is actually an atrophic condyle, an atrophic ramus on the left side, which has created this asymmetric bite. Now, when we set up the models to determine how this might be corrected, we find that it's a little bit difficult and doesn't go readily into a good position, but that by removing the upper left lateral incisor and doing a maxillary osteotomy, followed by vertical osteotomies in the ramus, that we can get a pretty good occlusion, and this is what we arrived at. This lady, prior to surgery, had constant headaches, nervousness, and generally felt bad. And as you can see in the appearance on her face, following correction of her asymmetry, her entire personality changed. Here's another asymmetry. It's a young boy who, before he went to high school, did not pay much attention to terminology such as bumpy jaw, horse face, and the other bad things that his friends called him because of his appearance. But on entering high school, these things began to bother him. He became very withdrawn, very depressed. His schoolwork became very poor, and he became asocial. Now, these X-rays show how much lower one side of the mandible is than the other. And this is a photograph that was made of this young boy the evening before surgery. Now, this was somewhat of a complicated case, requiring intraoral osteotomy and sectioning of the lower border of the mandible a large segment of bone was removed from the lower border of the mandible on the left side. As you see demonstrated, the bone has been removed here, and I think we have a slide showing that piece of bone. That's a pretty large hunk of bone. The anterior point of the chin was also reduced, and because of an open bite on the left side, we did a vertical osteotomy on the ramus through an external approach, with a very nice result. Here are post-operative x-rays. Following surgery, this boy's attitude changed. He started dating, he started participating in school activities, and his grades picked up remarkably, and he was converted from a depressed youth to a very normal, industrious young man. We have some photographs, some serial photographs on this boy that were made prior to surgery, as you see here, and shortly after surgery, as you see in this photograph, and another photograph made about 3 years later. As you can see, he is very well adjusted and certainly has no noticeable deformity. Looks a little bit like Hugh O'Brien. That may be Hugh, I don't know. Well, here's a girl who has a problem. She doesn't have a severe prognathism. She has an end-to-end bite. Now, her dentist would like to make porcelain jacket crowns for her, but he can't make them with that bite relationship. It just so happened that she had lost both of her lower first molars, so we were able to then do body ostectomies bilaterally in the first molar areas and set that lower jaw back a little bit so that porcelain jacket crowns could be made. Now, the strange thing about this young lady was that prior to surgery, she was an A student at Rice University, very asocial. After surgery, she began dating and mixing around a little bit, and her studies, as a matter of fact, dropped so severely that she had to drop out of school. But she got along and was adjusted very well, maybe too well. But these things do happen. Now, here's another one. This girl has a prognathic mandible. We set her jaw back to put the teeth in a normal relationship, but weren't quite happy with the result, and we then proceeded to reduce the point of her chin through an intraoral incision. As depicted here, with this very nice result. Now, this girl had been a spinster. She had never dated. And after we did this surgery, she got married and had 3 children and tried to blame it on us, but we don't accept responsibility for that sort of thing. That's a chance you have to take. These are x-rays showing the severity of her prognathism, before and after. And I believe we have a Panorex now. This after picture was made 12 years after her surgery. This Panorex is also made 12 years after surgery. It shows you the readaptation of the ascending ramus, yet you can still see evidence of the osteotomy performed 18 years earlier. It's a very ingenious young matron that we did an osteotomy on for prognathism. She got 3 young children. She came in the office one day wearing this gadget, and I asked her what the problem was. She says, well, her kids kept bumping her in the jaw, so she went out and bought herself a fencing mask, and she thought maybe this idea might work out for some of my other patients. Marina's Family Home for Aged Women of the Sea. I don't know where that came from. How about that? I didn't know those things existed. This is a girl that I have been treating over a period of 16 or 17 years. I first operated on her when she was 23 months old. She had a infection of the umbilicus, and she developed a metastatic infection in the parotid gland, and subsequently an ankylosis of her right temporomandibular joint. And we made several attempts to free that jaw up each time the bone reformed and her ankylosis recurred. Now, we got her up to this stage when she was about 15 years old, and she had no chin. She had a very severe psychological problem, and that her classmates were teasing her and calling her all kinds of funny names, and of course she had no boyfriends, and she was quite disturbed by it. But we did get her mouth open to the extent that the orthodontist could do some work on her. So he got her teeth shifted around so that surgically we could reposition her and at the same time work on her ankylosis and put her and give her a much more favorable appearance. The Panorex shows you on your left the osteotomy site. That was the side of the ankylosis, and at the time you see it here, it had been operated on, perhaps 3 or 4 times. And that's what she looked like prior to our last procedure. The last procedure involved going back in on her right, which is your left, and removing bone in there. When we took a piece of silastic out, we freshened that stump and covered it with a dermal graft. On the right side, in order to advance the mandible into the position that we wanted, we did a C osteotomy. The C osteotomy is demonstrated in this Panorex. In this slide, you may see the piece of silastic that was removed from a previous operation. This is the stump of the mandible on the right covered with a dermal graft. And a Panorex made 6 weeks later shows bone regeneration in the osteotomy site. This is an X-ray at the beginning of treatment prior to orthodontics, and a cephalogram after surgery showing the new position of the mandible. This is a post-operative appearance of the same individual. And a photograph of her occlusion. This young lady now can mix with her friends without feeling inferior, and she is a much changed person. This young lady had an ankylosis, which we treated in somewhat of a routine manner. She had been injured at the age of 2, and this thing had developed over a period of 14, 15 years. And this was the limit of her opening. We did an osteotomy on the involved side and put a piece of silastic in the gap. And after surgery with a bite block, we were able to open her to 35 millimeters. And on her own, she could open to almost 30 millimeters. This was a week after surgery. Now, we let this young lady go home, and she missed several appointments. And finally, in desperation, I wrote the referring doctor and asked him what happened to her, and this is the message I got from him. She missed her appointments with you for the following reasons. She eloped and got married without her parents' consent, the cause being uterine neoplasm. She now opens to 37 millimeters and has good function. It is doubtful that she will return soon. One is inclined to draw conclusions from this experience that the successful release of condylar ankylosis can lead to an amorous facility resulting in matrimony. But this is the photographs that he sent us. He was able to get her to come into his office, and she can open up like an alligator. She got 50 millimeters in there. 40 anyway. Excellent opening. This I show you as an example of a normal emotional outlook, or supernormal. This very good lady had an atrophic mandible. We did a very large operation on her to rebuild her ridge. It took us 9 hours. We used 2 ribs and her hip, and she was in intensive care for about 2 days, but came out of it very nicely. She had no fear ahead of time, and afterwards she thought we'd done a great job. This is the way the graft looked on the alveolar ridge before closing the mucosa. She did get a very nice result so far as the graft was concerned. It was about 100% take, but she had to go through an awful lot of suffering to get it. but it didn't seem to bother her very much. It bothered us a lot more than it bothered her. She also had a posterior lingual ridge extension, and these are the permanent dentures that she's wearing. You can see the long elongated phalanges on the posterior lingual will help give her retention, and she has excellent function of those dentures and remains a very happy lady. I always like to get back at psychiatrists. This is a psychiatrist's wife. She's prognathic. Her symptoms were nausea, headaches, general bad feeling. This is a photograph made when she was a little bit younger. She felt that, and she had pain in her temporomandibular joints, and my associate recommended that we do surgery and move that jaw back. And of course her husband, being a psychiatrist, told her it was all in her head and there was nothing to it. But we did do an osteotomy and move her jaw back into a normal relationship, and all of her symptoms disappeared. And now she's laughing at her husband. And finally, this gentleman was a trapeze artist with the Shrine Circus. They had played first in San Antonio, and by the time they got to Houston, there were 29 injuries in that circus and 1 death. There was a death here in San Antonio. But the particular night that I was at the circus, I went there, I got a free ticket because I was the doctor that night, and this was the first act, and when he came out, it was obvious that he was nervous and upset. And he hadn't been out there 2 minutes before he fell off that trapeze. And he and I spent the rest of the evening in the emergency room over at the Memorial Hospital. This is to point out, to remind you that even old pros can be nervous. It's been our objective to demonstrate the significance of psychological factors in the management of surgical diseases.
Psychological reaction in oral surgery with Edward C. Hines, MD, DDS, Chairman, Department of Surgery, University of Texas Dental Branch at Houston, and consultant in oral surgery for the United States Army and Veterans Administration, was produced by the Television Division, Brooke Army Medical Center, Fort Sam Houston, Texas.